we can discuss if you'd like.
Good morning, Chair Volendroff, members Garrett and Holmes, staff and guests. The lobbies are open and the recording has begun.
Good morning. Thank you, Gretchen. I'll now convene the board caucus meeting for Tuesday, November 18th, 2025. And going to our first agenda item is approval of meeting minutes from 2022. So board member Garrett, I'm looking to you for a motion to approve the minutes as listed on the agenda this morning.
I move that we approve the meeting minutes as listed on the agenda.
Thank you, and I second that, so moved. So going right into our first agenda item, we have Tyler Watson and Nick Gladowski from our research team here this morning to provide us a research program roundtable update. So Nick and Tyler, I'll turn it over to you this morning.
Thank you. Good morning, Chair Volendroff and members Holmes and Garrett. Let me share my screen and we'll go ahead and get started. Thanks for having us here this morning. Can you see my screen okay?
Yes, we're good.
Great. I'll go ahead and get started. My name is Tyler Watson. I am the research specialist at our research program here at LCB. And Nick?
Morning, Chair Volendroff, members Garrett and Holmes. I'm Nick Gladowski. I'm the research analyst with the program.
Morning.
So this morning we'll be giving a brief update and overview of the research roundtable that we had just about 2 weeks ago on November 5th. So just by way of background, research roundtables were kicked off this year. This was our third one of 2025. The purpose of the research roundtables is to invite regulators and researchers from our agency, from Washington State, and as well as from outside Washington State, to engage in an open forum for learning and discussion as well as collaboration. So one of our outcomes beyond just sharing is to identify opportunities for collaboration. So the topic that we chose for the autumn research roundtable was kratom or kratom, depending on how you pronounce it. I wanted to point out that this is not a substance that LCB regulates, but as it is a research roundtable, we are interested in learning about emerging substances, latest trends, and things like that. So we thought that this would be an interesting opportunity to talk about this emerging topic and invite some experts from both, again, Washington State as well as outside the state. So that was the topic that we chose. I'll go ahead and give just a brief overview. So some of the presenters and guests from this roundtable included Dr. Jimmy Leonard from the Washington Poison Center, who talked about exposures with nationally to national poison centers. Dr. Oliver Grunman from the University of Florida College of Pharmacy, who is one of the nation's foremost experts on this topic. Dr. Matthew Rosheim from the University of North Texas, who is a well-known public health researcher and expert that we've collaborated with a number of times, and LCB's own Mark Webster to round out the discussion and expertise on this particular topic. So we had several presentations we'll overview in just a moment, but I thought it would be interesting to just briefly show. We had 87 attendees for this meeting. We had a little over half of those were from LCB, from our agency, about 60%, and then the remainder were external. And that external group included researchers from both major research universities in the state, University of Washington, Washington State University, as well as a few researchers and regulators, again, from across the state, but also outside the state, including as far away as Maryland and Florida. So we were pleased with the sort of diversity of attendees. We thought that this was a topic that drew a lot of interest, and we had an opportunity for some good learning to happen. So I will, so we just have a few slides just to do a quick overview of the content. I'll start and then I'll hand it over to Nick. So our research program, Nick, myself, and Dr. Sarah Oki, who's the manager of the research program, kicked off with just a Kratom 101, talking about what this substance is and some of the basics. So very quickly, Kratom is a tree-like plant from Southeast Asia that's been used for a really long time. For example, in brewing of teas, there's been a lot of increasing interest because it's become very prevalent in places like the United States, available in places like corner stores and gas stations. And we see that there's an increasing interest from things like Google searches, and as we'll see in a moment, also in exposure data. It's not yet regulated at the federal level. There's been attempts to, but it hasn't happened yet. So in lieu of that, states have taken different approaches, as they do. Some states have chosen to regulate. A few states have banned it, and then there's other states, including Washington, who have not yet done anything about with respect to regulations yet. And then there are definitely health concerns. Kratom has what we call dose-dependent health effects. At low doses, it has a stimulating effect. At higher doses, it has an opioid-like effect, including, and that can include depressive effect of physiological systems. And so there's a lot of concern about this is an opioid-like substance, and with that, one of the two active ingredients in kratom, mitragynine and 7-hydroxymitragynine. 7-hydroxymitragynine, or 7-OH as it's called, is naturally present in very small amounts, but it's being concentrated in amounts that you would never find in nature and being made available in products like you see over on the right-hand side. So there's concern that these highly concentrated products are becoming widely available. Over to Nick.
Thank you.
Thanks, Tyler. So I'm just going to give some really quick takeaways from the other speakers that attended the roundtable. So I actually presented a draft of a dashboard that we've been working on in collaboration with the Washington Poison Center. We recently acquired data for Poison Center calls related to liquor, cannabis, tobacco, as well as kratom, because it is an emerging substance of interest. And I just wanted to point out two really quick things. Because of our collaboration, the Poison Center was able to provide us with data for 2025 so far, in addition to the prior years of data that we already had. So if you look at exposures by year, you can see that the number of exposures is generally increasing, but especially if you look at 2025, just through September, there have already been 97 exposures. So we are on track for a new record number of exposures to kratom in Washington in 2025. The other point that I just wanted to quickly make was that in the bottom left corner, you have kratom versus 7-OH. So the Poison Center only just recently started coding 7-OH as separate from kratom. They began coding in February, but our collaborator Jimmy was able to recode cases from January as well. So you can see that while this is an emerging substance of concern, only about 2.5% of calls related to kratom as a whole are specifically for 7-OH. Next slide, please. So next, Dr. Jimmy Leonard with the Washington Poison Center shared some national Poison Center data from a project that he's working on. And the biggest takeaway, which you can see here, is that the number of kratom exposures nationwide has seen a major increase over time. And specifically in 2025, you can see the last two time points are January and May of 2025. And he and his team of researchers are working on a project to compare kratom exposures in 2025, when we're seeing this huge increase, to past exposures, to see if they can find any differences and try to explain why we're seeing such a large increase now. Next slide, please. And then finally, we had a panel discussion, and Dr. Oliver Grunman, who, as Tyler said, is a leader in kratom research worldwide, and we were very excited to have at our research roundtable. He gave a brief presentation on the pharmacology of kratom, and I think one of the biggest takeaways from his presentation, and kind of as Tyler and I have both discussed up to this point, is that all kratom products are not necessarily the same. And this is especially true with the proliferation of these 7-OH products. So native kratom leaves contain about 1 to 2% of metragenine, which is the primary psychoactive component. Some extracts and concentrates can contain more than 40% metragenine, and now we're seeing products containing this 7-hydroxymetragenine, which is 40 times as potent, estimated 40 times as potent as metragenine, that are also becoming more common in the market. So thank you, and I'll hand it back over to Tyler.
Thank you, Nick.
All right, just 2 more slides here. One is, and these 2 slides are some next steps and takeaways. So as a next step, something that we've initiated in partnership with the Washington Poison Center is what we're calling an environmental scan. We are asking partners across the state to actually submit observations, submit photos of products that are being sold in Washington State in corner stores, gas stations, other locations, so that we can get a sense of what is actually out there. Again, to just help to better understand the scope of these products in our state. So this link will take you to a survey that you can submit photos to. You can also email the research program. The email's down there at the bottom, LCB research at lcb.wa.gov. We can also send this flyer as a PDF. And we've got this being shared out with several of our partners across the state. So we'll be summarizing that at a future date.
Great.
And then finally, we wanted to share a little bit of feedback. So at the suggestion of Chair Vollendroff, we have initiated a feedback survey for the for each roundtable. Uptake has not been super high yet, but we did get a handful of responses. We got 6 responses from this initial roundtable, and so far it looks like most folks who responded were pretty satisfied with the roundtable overall. In particular, the opportunity to listen and learn about relevant topics, getting 9.2 out of 10. But we might have some room for improvement on the discussion piece, facilitation of discussion. We got an 8 out of 10, and opportunities for collaboration, a 7.7 out of 10. And we kind of think that that's because we had just such good presenters for this one that we kind of didn't really quite leave enough time at the end for that discussion. That is a goal of the roundtables. But so for future, we will be being a little bit more intentional about making sure we have some dedicated discussion time, because we do want collaboration to be one of the outcomes of these roundtables. So we'll be talking about with our team about identifying dates for 2026 roundtables, and we will be sharing those out shortly. Thanks for having us. Any questions?
Great, thanks so much. And I'd say 8 out of 10 for facilitated discussions, pretty good. So I appreciate you sharing the evaluation material. First of all, let me say I participated in this. So Board Member Garrett and Board Member Holmes, I was present. I thought the panel was excellent. The discussion was excellent. And I have more to say, but I'm going to defer to Board Member Garrett, who I see has a comment. And so Board Member Garrett, I'll turn it over to you.
Yeah, I'm not familiar with the kratom. So when we say folks in the Poison Center, what are people, what's happening? What are they experiencing from this product?
So essentially, why are people calling the Washington Poison Control, right?
Right.
Yeah, Nick, do you want to take that one?
Sure. Yeah. So people oftentimes call a poison center if they maybe think that they've consumed too much. They're experiencing effects that they maybe weren't anticipating. So it's a lot of people experience things like elevated heart rate, or they're experiencing psychoactive effects that they weren't anticipating. There are some major effects of kratom that can occur, so there may need to be medical intervention, but other times it is minor effects that are more transient and that subside on their own. So it can be quite a range of effects that occur.
So when we say some states have banned it and some states have regulated, um, on the ones that ban, do we know what the other states are saying about this product?
With respect to exposures,
Yes.
like the Poison Center calls, that's a great question. I don't know if we went into that detail in that analysis.
So, I mean, a lot of the effects of kratom are not super well understood, and because it's not regulated, there can be things like contaminants that also appear in the products themselves. So rather than try to regulate and make some sort of mandated testing, some states have opted to ban kratom entirely. It does at high doses have opioid-like effects, so it'll act similar to other opioids. But it's not a substance that we understand as well at this time.
So are we trying to, right now, this is based on us trying to understand it and know what the impact with Washington State and what we should do or should not do?
Yeah, I'll take that if I could. So I think this came partly after a board or caucus meeting recently, Board Member Garrett, in which we were exposed to the fact that this was occurring, that we were hearing more from poison control and that kind of stuff. And so I think it's really an attempt to just stay ahead of the curve of what's happening out there. I don't know whether Washington State will do anything or not. I would anticipate at some point we may see some action regarding this, but at this particular point, this is just to inform us. There's a number of unregulated products out there on the market. And I would say when I'm talking to the prevention and research community, and when I'm hearing from E&E, I hear a lot about products that are not regulated in general. So this is just one of several different products that are out there on the market that are unregulated, and just to keep us informed should something come up around potential regulation, since we're seeing this in other states.
Okay, so yeah, I was trying to understand what we were doing here,
Yeah.
discussing and why. Okay,
Yeah.
all right, thanks.
Okay, Board Member Holmes.
Me too, Board Member Garrett. I'm trying to learn as well. So I'm excited about the collaboration to identify products that people want to just alert the Poison Control Center and LCB about. I would love to hear future progress on that. And I wish we could also all three attend these roundtables at the same time, but I really appreciate our chair giving us feedback on it. I had a minor question for Nick on one of the graphs that you presented that showed the 10-year experience of calls to the Poison Center for kratom. And it looked like there were different months. And I wonder if you can tell me, was that just peak usage in that year, or what was the reason for a different point in each year that you had the data point?
Yeah, Tyler, I don't know if you want to put that slide back up. That was from the presentation that Jimmy Leonard with the Poison Center gave, and that was a look at national trends, and that would have been the number of calls that occurred. It looks like they split the year into 3 time points, so the number of calls that happened kind of triannually. So across the,
Okay.
yeah.
Okay. And then last question, is there any confusion when you're doing this research about references to K, whether they mean kratom or ketamine? Because again, we do have a broad spectrum of substances out there, and it's a brave new world on how to regulate.
Yeah, I have not heard K be used to refer to kratom, me personally. Not to say that it never is used, but I've heard it as reference to ketamine, but not kratom myself.
Okay, I've heard both, but
Okay.
that could be my confusion. Thanks.
All right, thanks so much. And again, just finalizing the conversation. if you, this to my fellow board members, if there's other unregulated substances that you're hearing about and you'd like to be briefed, I think it's a fair ask of the research team to consider potentially hosting a roundtable on it. Not to say that they will, but please do let the research team know if there's other unregulated substances. And I don't know, again, whether something will happen at our Washington State legislature, but because this is happening nationally and everywhere, as you heard, from a ban to some form of regulation, I felt like it was appropriate for us to get ahead of the curve, be aware of what's happening nationally in the event that we start seeing some action at the state level. So that was the purpose of the roundtable. Okay, any other questions or comments for our research team? All right. Well, Nick and Tyler, thanks so much. Really appreciate you being here, and the work that you did. It was really quite excellent. So thank you.
Thanks.
Thank you.
All right, we will now transition into our next agenda item, which is the Washington State Institute for Public Policy publication, Impact of Cannabis Retail Availability on Cannabis and Mental Health Outcomes Among Medicaid Recipients. This morning we have with us from WISIP, Dr. Amani Rashad. And Dr. Rashid, welcome and appreciate you being here this morning. Good to see you again. You've presented to the board before. Just a reminder to the board, when Initiative 502 was passed, the Washington State Institute of Public Policy was tasked by the legislature to publish a number of reports over several years. And this is just one of those, and I'll let Dr. Rashid give background on that. So Amani, I'll turn it over to you.
Thank you so much for that introduction. And it's good to be here. Thank you all for inviting me again. So as mentioned, I'm a senior research associate at the Washington State Institute for Public Policy, or WISIP as we call ourselves. For the uninitiated, WISIP is a public nonpartisan research group, and most of our work is at the direction of the legislature or our board of directors. So most of our work comes via bills directly from the legislature, or we can contract with agencies. We've actually done that with the LCB before. As board member Vollendroff mentioned, this is interesting because this work came through Initiative 502. So getting work via an initiative is a new thing. But before I jump in, I did want to mention that with this work, and really this report in specific and the work we do in general, I receive ongoing support from the research team. So Tyler, Nick, and Sarah help me out and provide feedback along the way, as well as Kristen Haley. So a shout out and a thank you for their ongoing work and support. Also for this report, we do have information about operational retailers in the state. Those data did come from the LCB as well. So a thank you to the team that pulled those data for us and supported us there. So we'll just jump into it. This report is the impact of cannabis retail availability on cannabis and mental health outcomes among Medicaid recipients in Washington State. As mentioned, this is part of a larger assignment. So Initiative 502 tasked us to conduct a long-term benefit cost evaluation of the implementation of Initiative 502, considering outcomes related to public health, public safety, substance use, criminal justice, economic impacts, among other outcomes. And in addition to defining the scope of the study, the assignment also mandated 4 deliverables. So we published a report in 2015, 2017, 2023, which is what I last presented. I gave you a brief on those results last year. And then all of this work will culminate into that final benefit cost evaluation in 2032. So in the intervening years, as we receive ongoing funding, we continue to do research that lays the requisite groundwork, the foundation that will be required to conduct that final comprehensive benefit cost and economic evaluation. So this report is a piece of that foundation building.
Thank you.
So a little bit of the motivation for this specific report, as you saw, the scope is quite large. There's many things we need to study. We started here in part because if you look at the full assignment language, there's a lot of emphasis on maladaptive cannabis use disorder diagnosis, cannabis-related substance use, and healthcare costs related to cannabis use. So we're starting here. Furthermore, our previous work in 2023, if you remember, in that work, we examined the relationship between access to operational licensed cannabis retailers and cannabis use, and we did find that greater access, so retailers in closer proximity and higher density of retailers did relate to higher reported rates of past month cannabis use and frequent past month cannabis use. So this work is just building off of that. In that report, we actually did start our healthcare work, and we looked at cannabis retail access and cannabis use disorder diagnoses among the Medicaid population. So this study is largely just building off of that work, in so much as we are looking at more years of data. The previous study looked through 2019, and now we're able to look through 2023, so we can see how outcomes are evolving over time. And in this study, we look at more outcomes, so we expand the healthcare outcomes we look at. In particular, we'll look at cannabis use disorder diagnoses again, but we'll also look at cannabis use disorder related hospitalization, cannabis use disorder related inpatient substance use treatment, and mental health disorder diagnoses. There is a robust and growing literature that links cannabis use, especially disordered cannabis use, to mental health disorder diagnoses. There's an established association, so we'll look at that as well. Now, this study, like our previous work, focuses on the retail component in particular. This is a cannabis use outcome, and retail is how we acquire, or at least the legal age population, how you legally purchase cannabis. So to motivate the study design, i.e. the comparisons that the study makes to estimate its conclusions, this is a map of census tracts in Washington in 2023. And in the green census tracts, the average resident of that census tract, so the average resident of that neighborhood, can get to their nearest retailer within a 10-minute drive time. So in these neighborhoods, we say that retail is accessible. They have easy access. Sometimes I'll refer to them as the treatment neighborhoods. And in the yellow census tracts, the average resident needs to drive more than 10 minutes to get to their nearest retailer. So in these neighborhoods, they don't have easy access to a retailer. That's how we're designating it. I'll sometimes refer to them as the comparison census tracts. So here we can compare differences in healthcare outcomes for the average resident of a green census tract versus a yellow census tract after the retailer opens. So that's the comparison we're making. We want to see systematically in the state over time and space, as retailers open, do we systematically see changes in cannabis-related healthcare outcomes? So in sum, or to reiterate, we are estimating the change in outcomes between census tracts with the retailer within a 10-minute drive time to those without, before versus after the retailer opens. So it's nice because we have data that goes back in time. We can go as far back as at least 2014. So the nice thing here is we're able to look at changes both over time and across the state. The nice thing about being able to make two comparisons is it allows us to just better home in on the relationship between the retailer opening and the changes in healthcare outcomes. So we're able to better isolate that from all the other things that are moving around. So our outcome data is the annual Medicaid claims data, as I mentioned before, and we have data spanning 2012 through 2023. So this is the data of all Medicaid enrollees between the ages of 12 and 64. So we actually have information on the underage population. All of our analyses separately examine the underage population, 12 to 20, from the legal age population, 21 to 64. And all of our models account for individual characteristics such as sex, race, age, and so on, and census tract characteristics, so neighborhood characteristics like unemployment rate, population size, demography, and so on. So we're able to account for a lot of moving parts. Again, this is just allows to better isolate that relationship between retailers and healthcare changes. Now, the outcomes we are looking at, I'll highlight 4 of them in this study. The first is cannabis use disorder diagnoses. So Cannabis use disorder diagnoses, the way it's being defined in this study is on a claim if a provider indicates a diagnostic code that relates to one of a set of different diagnostic codes that are related to cannabis use and abuse, then we flag it as a disordered use diagnosis. So it's no one specific diagnosis, it's any one of a suite of diagnostic codes that could be that. We also look at cannabis use disorder related hospitalizations. So the way this is defined is if you within the year received a hospitalization where cannabis use disorder is listed as one of the corresponding diagnostic codes. So it's important to note for this outcome, it's not necessarily that the cannabis use is literally the reason you are being hospitalized. It could be that you're being hospitalized, for example, for an injury, and the provider just also notes cannabis use disorder. We can't, in our data, we can't separate out the two, so it's kind of a catch-all. The next outcome we'll look at is cannabis use disorder related inpatient substance use treatment. So similarly with this, it could be that you're receiving inpatient treatment literally because of the cannabis use, that's the primary, or it could be a different disorder like opioid use disorder, and you also happen to have cannabis use disorder. Again, it's a catch-all, we can't separate. And then the last set of outcomes I'll be presenting on is the co-occurrence of a cannabis use disorder diagnosis and any one of anxiety, depression, bipolar, or psychotic disorder. So this would be a case where there is a claim associated with the person that lists both disorders at the same time on the claim. So we'll be looking at how the prevalence of this changes over time. So to give you an idea of scale, these outcomes are relatively rare. For example, cannabis use disorder is not diagnosed, it's diagnosed about like no more than 3% of the sample ever receives one of those. And a lot of the other outcomes happen even less, some less than 1%. So not to diminish the importance of the outcomes, but for an idea of scale, these are relatively rare outcomes, especially among the underage population. The last thing I want to note before I jump into the results is a reminder that these results are derived from and speak to the Medicaid enrolled population. So in Washington, about 23% of the population is Medicaid enrolled, I believe. We cannot take these results and generalize to the greater Washington population. We would have to study the greater population or different populations to speak to them. This only speaks to this population. So now jumping right into the results. First, here what we're looking at is the predicted probability of cannabis use disorder diagnoses by retail access designation and age group. So to walk you through how to interpret this, if we look to the left, the underage population, the y-axis is the probability of receiving a cannabis use disorder diagnosis as predicted by our model. So this is our model saying that among the group that has no retailer nearby, they are diagnosed with cannabis use disorder about 1.6% of the time. And the green bar tells me that among those with retail access, they are diagnosed with cannabis use disorder a predicted 1.8% of the time. That difference is about 13%. And the stars here indicate that that difference is statistically significant. So if you put all of that together, this is saying that in neighborhoods where there is a retailer nearby, we predict a 13% higher probability of a cannabis use disorder diagnosis happening among the underage population. Again, to give you an idea of scale, that 13% relative to the average translates to about, I believe, 2,800 more claims. So that would be 2,800 more claims where we see this diagnosis. Following the same interpretation to the legal age population, this is telling me that among the legal age populations, on average, those who reside in a neighborhood nearby a retailer are about 7% more likely to receive a cannabis use disorder diagnosis. So for scale, remember the outcome is more common among this group. So the 7% relative to the average would be about 12,000 more claims listing cannabis use disorder per year. Sorry, I didn't give you a scale of time, but that would be annually that many more. So with these results, what comes up often with these studies is, okay, so I see this. Is it the case that the disorder diagnoses went up after the retailer opened? Or was it the case that cannabis use disorder was already on the rise at a higher rate in these neighborhoods? and the retailer happens to open there. So a little bit of a question of, did it cause it or was it already on the rise? And in the absence of being able to randomly put retailers across the state, we can't definitively establish cause and effect, but we do have tools that allow us to look at, okay, well, before the retailers opened in these neighborhoods, how did trends in cannabis use disorder rates look like? What did they look like before the retailers opened versus after they opened? So what you are looking at is called an event study analysis, and it allows us to do just that. It allows us to look, okay, the difference in cannabis use disorder rates in the treatment versus comparison groups in the years before versus the years after. So the x-axis is years relative to the retail opening. Year 0 is the year it opens. So year -1 is 1 year before it opens. The circular markers are the difference in the rates between the treatment and comparison group. And then the vertical lines are a measure of uncertainty. If they cross 0, it just means it's statistically insignificant. So if you put all of that together, what this picture is telling us is 1 year before the retailers opened, there was no significant difference in cannabis use disorder diagnosis rates between treatment and comparison group. 2 years before, there's no difference. 3 years, 4 years, 5 years. We don't see a difference in the years before the retailer opens. But in the years after the retailer opens, especially when you hit year 2 onwards, that's when we start to see that significant increase, that the treatment group is experiencing higher rates of cannabis use disorder diagnoses. So this is telling me among the legal age population, this 7% increase is likely, this is providing corroborating evidence that this 7% increase is likely occurring after the retailer opens. It wasn't that it was already going up at a higher rate. So important to know, I'm only going to show you this one, but we did look at this kind of analysis for all of our outcomes. And especially among the legal age population, we generally see this pattern hold where increases in healthcare utilization rates tend to go up only after the retailers open in the neighborhoods. So other outcomes we look at, again, focusing on the legal age population here. Among the underage population, we looked at these outcomes and didn't see statistically significant differences. You can refer to the report for the full results. But what this is telling us is among the legal age population, after the retailer opens, cannabis use related hospitalizations are 7% higher in neighborhoods with a retailer nearby. And after the retailer opens nearby in those neighborhoods, cannabis use related inpatient treatment is 24% higher. So 24% is quite large. We haven't seen a number that big yet. Again, for scale, this is a pretty rare outcome. A 24% increase would be about 1,500 more cases, more claims of inpatient treatment annually. So the last set of outcomes we'll be looking at is the co-occurrence of cannabis use disorder diagnoses and any one of these mental health disorder diagnoses. So here we do see significant results for both the underage and the legal age population. But what this is telling us is among those aged 12 to 20, after the retailer opens, we see about a 12 to 14% higher probability of receiving a co-occurring diagnosis of cannabis use disorder and anxiety, depression, or psychotic disorder diagnosis. And among the legal aged population, we see that a retailer opening nearby predicts anywhere from 10 to 20% higher probability of the co-occurrence of cannabis use disorder and any one of these mental health disorder diagnoses. So the results so far have focused on the definition of access being proximity. Is there any retailer within 10 minutes? Is there any retailer nearby? We did also look at density as a measure of access. So how many retailers are nearby? And so to give you, again, the report has the full results. I'll just show you the results for the cannabis use disorder diagnosis outcome. But here we look at, okay, in a neighborhood, do we see a difference in outcomes if you have no retailer nearby versus one retailer within 10 minutes versus 2 versus 3 or more retailers within a 10-minute radius? And we do find that it would appear that most of the impact, the highest impacts, are actually happening in neighborhoods with a higher density. So 2 or 3 or more retailers predict higher increases in cannabis use disorder diagnosis for both the underaged and the legal aged population. I also want to note this is just for cannabis use disorder diagnosis, but this pattern that more retailers predicts higher impacts is persistent across all the outcomes we look at. So density matters. It could be, and I'm sure you're all familiar with this or have thought about this, it could be that where there are more retailers, there's more market competition. Could be that prices are lower, so use goes up. That could be a driver. It could be higher advertising. We know, especially among youth, that they're very susceptible to advertising. So that's another way density could drive up use. It could be that as retailers try to differentiate their products, we have higher THC concentrations or different types of products. All of these are potential mechanisms to explain it. I don't have any information about prices or inventory or advertising or market operations, so I can't empirically assess why density matters, but we do know that it does. So there are several other findings in the paper that we could go on and on about, but I think for the sake of time, that's highlighting a lot of the main ones. So just to reiterate, the takeaway here would be that nearby retail access does predict higher rates of cannabis use disorder related healthcare utilization and mental health disorder diagnoses. And evidence, again, especially among the legal age population, would indicate that these changes are happening after retailers open in the neighborhoods. There are several limitations to the study, of course. I've already listed some. I think a notable one to highlight is that we have limited information about the medical history and healthcare use of these individuals. We don't know if they have other comorbidities that could explain some of these outcomes. We don't know their entire history of healthcare use. We only can go back to 2012. So we'd want more of that information to highlight what's kind of what's going on in what context we see these changes. Importantly, we don't know anything about their cannabis use. So I don't see the type of product they use, the frequency with which they use it. We don't see any of that information. It's important to note many people use cannabis without exhibiting cannabis use disorder or having healthcare utilization. I can't observe the behaviors that lead to these outcomes. And I think that that would be an important next step. I'm not sure how one would study. I can't link those, but that is a notable limitation is we cannot contextualize this population or assess the specific risk factors that lead to these outcomes. And then just to reiterate, this is only pertaining to these impacts only speak to the Medicaid population. So they're non-generalizable, but also it means that whenever you study claims data, it doesn't speak to the uninsured largely and those without healthcare access. So unfortunately, they are omitted from this study. This remains a criminally understudied population. It's just a byproduct of using claims data. And then before we, with a final parting note, a little bit of a departure is just to give you an idea of future work. This project, like I said, it's ongoing, it's large in scope. We already have new projects underway. We kind of work at a 2-year cadence towards the long-term plan. So we're going to take a little bit of a pivot away from healthcare and focus on some public safety outcomes. In particular, we're trying to look at retail access and child welfare and workplace safety outcomes. And then longer term, I think the next one we'll pick up will be looking at employment and wages in the industry. So this will be pivoting to the economic impact and the market side. We've been wanting to get that off the ground for a while, and I think it'll be the next one we pick up. Thank you.
Great. Thank you so much. Appreciate it. So I have a question related to the next steps for you in terms of the legislature. When this was passed, the legislature tasked WISP with a series of these reports. Now, what's happening next with this particular report in regards to the legislature? Are you presenting it to a particular group? Have you already sent it to the legislature? What's happening next steps regarding this report?
Yeah, great question. All of our reports, when they're completed, so this one completed at the end of September, they publish publicly on our website so anyone can access it. And we particularly, we email and outreach to the relevant committees and legislators about it. And I actually already presented on this report at a work session for the Consumer Protection and Business Committee. So the way it works is we publish them, we notify them that it's published, and then as they invite us or ask us, we present on the results. Yeah.
Great. Thank you.
Yeah.
Member Holmes?
Thank you, Dr. Rashid. One question regarding future work, wouldn't it be helpful for policymakers to see an overlay of what criminal interventions were with regard to cannabis over time, before legalization, after legalization, and regardless of what medical outcomes or interventions might have been occurring at the same time?
Yeah, that's a great point. And I think that's why the assignment is so comprehensive in its scope and so long in its timeline. This is just one piece. We are hoping to look at other pieces. And we have previously done some work related to the criminal justice impacts. In particular, we looked at the evolution of cannabis misdemeanor possession convictions, because with legalization, there was a direct impact. And a long-term plan for this study is to look at look at and monetize those criminal justice impacts. So that is in the works. It's just different pieces happen at different times. But excellent observation, and that is within the scope of this work. It's on the docket.
Great. Thank you. Any other questions? All right, seeing no other questions, thank you again so much for coming. We appreciate it, and we'll see you again soon.
Yeah, thank you so much.
Thank you. Okay, so that concludes our the vast majority of our agenda, just board member and executive reports. So anything from board members to report on? Board member Holmes?
Just quickly, last Thursday, I had a very informative meeting with the Washington Hospitality Association, along with Director Lucella in downtown Seattle. Look forward to continuing the connections we made there, and perhaps we'll even have some observations from that meeting as well.
Great, thank you. And I also had one scheduled for tomorrow that, or not tomorrow, but Thursday that unfortunately I have to reschedule, but I'll also be meeting with them in the near future. The only other thing that I wanted to let you guys know about is we do have another public health prevention roundtable tomorrow at 1 p.m., 1 to 2:30. And this is the cannabis industry and public health folks together. And so Kristen Haley and I will be participating in that. And so just I'll keep you posted, and we'll provide an update after that meeting occurs. Okay.
I have a question. So on these round tables, they're public meetings, correct?
They're not public in the sense that all three of us participate, and they're not recorded. So I don't know if that answers your question.
No, because I was trying to get to whether or not they were public meetings, to get back to a statement that Pete made earlier as to why other board members can't participate. But if the outcome and all of the discussions is being brought to a board caucus, which is a public meeting, I'm just trying to see the why on the roundtable piece. Because the board members that, attending would be more observation, listening in, not discussing LCB stuff. So I was just curious, as on the roundtables, if the conversation is being brought to a public meeting, where the difference lies on board members attending.
Amen.
Yeah, I think that's a fair and good question. And I have to say, after the number of years I've been on the board, still get a little confused about that line, and tend to err on the side of just making sure that we don't put ourselves in those situations. But I'm happy to have conversations with the AG's office to get clarification, because there are times when we are allowed to, for example, go to the same training together, but we're not there making policy decisions. We're not engaging in policy discussions. We're there just observing and listening. So I can follow up on
Which
that.
is the same of the roundtables.
Yeah. I might have to adjust some of my questions, or because sometimes depending on the particular roundtable, I may or may not. I mean, if you guys are not there, I may say one thing, versus if other board members were there, I would probably participate in a different way. So, which is fine. I think yeah.
I'd like you to specifically ask, what if our microphones were disabled? so that we're purely a listening mode. Something like that seems pretty straightforward to me.
Okay, I will follow up and bring that back to a future board caucus just for an update of my discussion with the AG's office. All right, thank you. Anything else for today? Oh, go ahead, Nick.
I just wanted to chime in that one of the reasons that we don't have the research roundtable as being fully public facing is to help encourage participation from other people, like especially research and public health, who might not be as comfortable speaking out and participating if it was a fully public open setting. But I just wanted to say that for your consideration. Thanks.
Yep, great, thank you, appreciate that. All right, well, that concludes our meeting, so I'll now adjourn the board caucus meeting for today. Thank you, everybody. Have a great day.